management protocol in angle closure disease.
Yeah, so now that I told you that we have a problem, what do we normally do about it? I'm sorry, slide. Yeah. So basically, what is angle closure? And here, there's a fundamental issue here. Angle closure, we think, is mechanical obstruction of the filtering portion, that's a pigmented portion of the trabecular meshwork by the peripheral iris. And clinically, how do we detect it? On gonioscopy, we say if we cannot see the pigmented trabecular meshwork, we assume it's because there is apposition. You cannot see what's going on. And the definition that is now globally accepted is 180 degrees or more. If it is in this configuration, that's primary angle closure. So why don't we treat all patients? I told you there's a huge problem. I told you there are all sorts of issues happening. Why don't we treat all? The reason for this is there's very little data on progression, and I showed you this data on progression just now. The risk of progression of untreated angle closure was, PSCS was low, 20%. And what does non-visibility on gonioscopy actually mean functionally? It doesn't really mean that they're in close contact. It just means that you cannot see it. If they were in contact, you would be having pigment being deposited in the angle. So non-visibility is an anatomical configuration that predisposes to angle closure glaucoma. It is not pathology at this stage. So that is one of the reasons why we don't really advocate treating everybody with this. It does predispose to angle closure, but it probably does not restrict aqueous filtration, because if it was actually causing decrease in blood, if it was causing resistance to aqueous outflow, your pressure would increase. And this is what I'm going to show you. These are the numbers of the intraocular pressures of people with PSCS versus normal. And you can see that the numbers are actually not, in the rural population, were statistically significantly different, but in the urban population there was nothing there. And those numbers are not very different. So if the numbers are not very different, then this configuration is probably not doing very much to the eye pressures. So therefore it doesn't really make sense for us to rush in and do something when it is not really indicated. So what are the absolute indications? And the absolute indications are what have been reported by the CGIG and more recently by the GSI, that anybody, the fellow eye of anybody who's had an acute primary angle closure attack, because the other indication is somebody with a family history of PSCG, because if you have a family history of PSCG, there's a 4 to 6 times greater risk that you will develop PSCG. So if you see somebody with a narrow angle whose father, brother, sister, somebody has angle closure glaucoma, go ahead and do the YAG-PI even if there's no other risk factor. The relative indications are somebody who requires repeated pupillary dilatations, and this is with a huge number of diabetics. They form actually the single largest cohort of PSCS that you do a YAG-PI for. People with poor access to care, somebody in a remote village somewhere who may never come back, yes. One-eyed patients are again a relative indication for me to do a iridotomy for them. So even though we don't advocate YAG-PI for everybody, everybody needs follow-up and monitoring, and that is something that needs to be explained to the patient that you have a potential problem, please come in for a checkup. The other very useful thing to tell them is, please ask your family members to have a checkup. Because if you have PSCS, it's very likely that somebody else in the family has some other form of angle closure disease which actually needs treatment. When you come to PSC, PSC is not only Sinecare and high IOP, but if you have symptoms suggestive of intermittent angle closure, like pupillary rough atrophy, glaucoma flecken, or patchy trabecular meshwork on gonioscopy, or iris atrophy, these are also signs that this patient has had an intermittent attack, and these are patients who you would want to do a laser iridotomy for. So they have no disc or field changes, but there are signs suggestive of a previous intermittent attack or signs suggestive of intermittent apposition. So there's really no question about it. You do a YAG-PI, you reassess the angle and the intraocular pressure you manage medically. So what about if you have an acute primary angle closure attack? I'm not going to go into great details here except to say that you need to control the intraocular pressure, oral acetazolamide, injection mannitol if needed, if they're systemically okay, topical steroids, topical anti-glaucoma medications, start the pilocarpine only once IOPs come down. If the IOP has reduced, start the pilocarpine, do a YAG-PI, reassess, look for the disc, field and the angle, and especially gonioscopy in the fellow eye. So in primary angle closure glaucoma, now this is somebody with definite disc or field changes. Raised IOP or peripheral anterior synechiae are not mandatory for the diagnosis. So here what is the situation? you do the YAG PI, you reassess the angle, and intraocular pressure is treated medically and if required surgically. So the angle control you need to reassess. The story doesn't end when you do the YAG PI. The story ends when you see what has happened after the YAG PI. And in general, you would want to do the gonioscopy at least 72 hours after you have done the YAG PI, because the pilocarpine effect has to go off for you to see what is happening to the angle and whether it's still occludable. Keep in mind that you can have a Plato iris configuration in any phase of the disease, and about 25% of angles post LPI will not open up, and that can happen in PSCS, PSC or PSCG, and that's why it's really, really important to do a gonioscopy post YAG PI. And a Plato iris configuration typically looks like this with the double hump sign. So when you have Plato iris, what can you do to open up the angle? Because it is blocked because you have a bulky iris process sitting there. So what can you do to open up the peripheral iris? One thing that you can do is try pilocarpine. I typically would give pilocarpine once a day at night, and that is sometimes enough to just open up the angle. The other thing that you can do is iridoplasty, which I'll talk about a little later, or you can consider early cataract surgery in these patients. You can also observe them if they are amenable to follow up. You can observe them closely to see whether there's any progressive change in the angle, but here it becomes very important for you to document what you're seeing in the angle and look closely for any syndicate to form. So in iridoplasty, essentially you use a argon or a frequency double YAG to just put these spots in the periphery, and that causes constriction of the iris around it and pulls the angle open. And this is what it looks like on UBM. So you can see that this angle is fairly narrow there, and here post iridoplasty that peripheral iris has flattened out and the entry to the angle is open. The concern basically has been that in the long term, it doesn't seem to really keep the angles that open, and which is why we don't do it that often. So the general impression is the long-term effects are not that good. And I'd like to share with you the last few slides. This is the management algorithms for primary angle closure disease done by Dr. Ravi Thomas, who's one of the stalwarts of angle closure research in India, globally. And so basically what he's telling you here is angle closure is quite easy. Do laser iridotomy. If the angles open less than 180 degrees and the patient is uncontrolled on medical treatment with synechiae less than 180 degrees and a cataract, go ahead with the cataract. If there's no cataract, try a laser iridoplasty. If that doesn't help, then you may need to do a trabeculectomy if they progress to PSCG or IOPs, or the IOPs are not really controlled. If the angles open more than 180 degrees, manage it as an open angle. If the angles open less than 180 and controlled on medical treatment, if there is visually significant cataract, you might want to think about it. If there are no visually significant cataract, you can just hold on to it. If on indentation you have extensive PAs and the intraocular pressures are uncontrolled, if there is a cataract, consider doing a phacotrabeculectomy. If there is no cataract, again follow up, consider doing a trabeculectomy if the intraocular pressures are uncontrolled. So this is a fairly logical and sensible conservative way of managing angle closure glaucoma. So in the management of PSCD, not all eyes need treatment, but careful gonioscopy is required by all eyes, both at diagnosis and follow-up as necessary. Thank you.